Okay, Niteshwar, we are live now. You may get started.
Okay. Greetings, everyone. Good evening. Myself, Dr. Nityashri, working as senior resident at Jayanagara General Hospital, Bengaluru. Being the member of social media subcommittee on behalf of KCIAPM, I take the privilege to welcome you all on our second season of KCIAPM Path webinar for the month of May. At the outset, I request all of our viewers and audiences who have joined to share the link with your friends and colleagues so that they can join us in live and take the benefit of our today's talk. Now, before I invite today's speaker, here are some housekeeping notes for the audience. Kindly set your YouTube resolutions at a minimum of 720 pixels so that you can view our slides clearly. And kindly show your active participation by posting your questions at the chat box. We will take all the questions at the end. I feel honored to invite today's speaker, who is a renowned transfusion medicine expert, senior professor and head of the department, Transfusion Medicine and Immunohematology at St. John's Medical College and Hospital, Bengaluru. It's none other than Dr. Sitalakshmi S ma'am. Madam is known for her lectures on quality control in many national and international platforms and have many journals and literature written research papers in many national and international journals to her credits. Madam will be speaking to us today on the topic of the approach to the interpretation of bone marrow aspiration and its interpretation in Trephine biopsy. Over to you, ma'am. We all look forward to learn from you. Thank you.
Good evening, Dr. Nityashri and Dr. Aditya. Thanks for this opportunity. I'm so glad to be a part of the community of students and share my experiences. Actually, I'm a pathologist. So I think in the last over 30 years, I've spent all my life doing hematopathology and transfusion medicine. For me, both of them are an integral part of each other. So that's been my focus area of interest, and I'm glad to be amidst all of you and take you through this session. So I will just quickly share my slides. I hope you're able to see my...
Make it full screen, ma'am.
Yes, ma'am. Full
yeah,
screen.
done that. Can you see? I've actually made it full screen. Can you see it?
There's probably a lag, ma'am. Yes, ma'am.
Yes, ma'am.
Okay,
Please
fine. So I would request both of you, either Dr. Nityashri or Dr. Aditya, to let me know in case the slides are not visible or I'm not audible. Because yes, I was just telling you all, you know, if it's going to be a 50 minutes or 1 hour presentation and I'm going to keep looking at the screen and talking, not too sure whether there is an audience at the other end and whether my slides are visible and whether I'm audible. So I would require inputs from you just to let me know.
Sure.
Yeah. Okay. So thank you. So basically this session, I'm going to be I'm just trying to move to the next slide. Yeah. So I'm going to be discussing essentially what a normal marrow is. I'm going to be discussing briefly on the procedure for bone marrow aspiration and biopsy, because I think it's important for us to understand the technical details of bone marrow aspiration and biopsy, because unless the technique is good and then you will get a good preparation, only then you can make a meaningful interpretation. So that is essential for us to understand. And then I'm going to move on to briefly discussing the interpretation of bone marrow aspiration as well as the Trephine biopsy. I do have a very few cases. I will also be highlighting some of the pitfalls in interpretation. So essentially, we're not going to be covering the subject of various hematological disorders in great detail in this session, because I don't think this 1 hour is going to permit us to talk at length about each disorder. But the focus of this session is to approach, how to approach, given a bone marrow smear, given a Trephine biopsy, how to interpret it is what we are going to discuss. So basically, what is bone marrow? So bone marrow is a very vascular, loose connective tissue. It has a volume of about 30 to 50 ml per kg. And we all understand that bone marrow is essentially the hemopoietic compartment in our body. It is made up of the hemopoietic cells and the stromal cells, which are otherwise the supporting cells. So there is what is called the red marrow, which is hemopoietically active, which means there are erythroid, myeloid precursors and megakaryocytes. There is also what is called yellow marrow. That means marrow is essentially inactive, purely composed of fat. There is also a vascular compartment which is very important, basically the nutrient arteries, sinus, the central vein, and so on. So as I described, the hemopoietic compartment and the stromal compartment, these two compartments not only coexist, but they closely interact with each other. So when I talk about the hemopoietic compartment, it's the erythroid, myeloid, and the megakaryocytic series. Of course, there is lymphocytes in the bone marrow. Besides this, the stromal compartment, other than having a fibroblastic network, there are nerve bundles, there is extracellular matrix, there is macrophages, the adipocytes, definitely the blood vessels, the nerve bundles, the trabecular bone, the osteoblasts and osteoclasts. So the role of stromal compartment is to maintain the hemopoietic stem cells. It supports differentiation and maturation of these progenitor cells. So as I mentioned, they closely interact with each other. So this is a very diagrammatic depiction of the bone marrow. It will make you understand that there is the bony spicule, it's lined by the osteoblast and the osteoclast. And this diagram very clearly shows you that there are these big giant cells, which are the megakaryocytes, the darkly stained cells, the erythroid cells with a very deep blue cytoplasm, and of course the myeloid cells at different stages of maturation. You see band forms, myelocytes, etc., myeloblasts. Then you definitely also see some lymphocytes, eosinophils, some vascular channels. So this is a diagrammatic representation for us to understand what the marrow is made up of. We all know, we have learned in physiology, what are the sites of hematopoiesis. At birth, all the bones are involved in production of hemopoietic cells. But in adult life, it is essentially the flat bones. So the skull, the scapula, ribs, sternum, and the vertebrae, proximal end of the long bones. These are essentially composed of the red marrow in the adults. We must remember that in disease states where there is increased production of increased marrow activity, then this red marrow extends into the shaft of the long bones, and the cellularity of the red marrow decreases with age. So at birth, if the marrow is 90% cellular, maybe in an individual who is 90 years old, marrow is only 10% cellular. So if somebody is 50 years old, the cellularity is 50%. So it's very easy to understand this. So this is just to get you a feel of what are the sites. I'm sure all of you are aware of this. So when we look at bone marrow interpretation, we are looking at two things. One is the aspirate and the other is the biopsy. So aspirate is just putting in a needle and taking out the liquid material from the bone marrow, whereas biopsy is a tissue section. Let us see what are the indications of bone marrow aspiration. So when do we do an aspiration? We all know that bone marrow is a very painful procedure. One would be very reluctant to undergo this procedure. Therefore, when should we do it? So I should have absolute indications for bone marrow aspiration. It's not like doing a CBC or any other test where you could just order for it without any justification. So there could be clinical situations where there is unexplained anemia, macrocytosis or microcytosis, unexplained thrombocytopenia, pancytopenia, a leukoerythroblastic blood picture where we suspect a bone marrow infiltration, of course, suspected acute leukemias, myelodysplastic syndromes, myeloproliferative neoplasms, and chronic lymphoproliferative disorders. These are the general indications for bone marrow aspiration. Of course, I mentioned NHL, plasma cell myelomas and related plasma cell dyscrasias. Suspected storage disorders. Of course, today for storage disorder, there are many other simpler tests which are non-invasive, which could be performed. But bone marrow continues to be one of the indications for when you suspect a storage disorder. Whenever there is pyrexia of unknown origin and we want to do a culture on the bone marrow aspirate, we do rely on doing a bone marrow. And anemia related to immunodeficiency and other related disorders. Sometimes you want to confirm normal marrow after an allogenic transplantation. We also require bone marrow aspiration to be done as a follow-up and monitoring response to therapy. Similarly, we could resort to doing a bone marrow biopsy, especially when there is unexplained, again, leukoerythroblastic blood picture where you're suspecting a bone marrow infiltration, fever of unknown origin where you want to pick up a granuloma. When we suspect a hemophagocytic syndrome, evaluation of a patient where you don't really get an adequate bone marrow, myelomas, plasma cell dyscrasias, MDS, acute leukemias, again, storage disorders, suspected primary amyloidosis, diagnosis and staging of lymphomas. Sometimes you may have diagnosed lymphomas on a lymph node biopsy, but when it comes to staging, you still have to do a bone marrow aspiration, hairy cell leukemia and other lymphoproliferative disorders. When you suspect a metastasis, as I said, staging, follow-up of small cell tumors of children, myeloproliferative neoplasms, aplastic anemia. So there's a whole list. But remember, one should justify the need for a bone marrow. It has to be an objective decision. And the second part that I would like you all to remember, that it's always good to do a bone marrow aspiration and biopsy together. Why, I will tell you subsequently. So let's briefly discuss about the collection. How do we get a bone marrow sample? All of you must be familiar with the bone marrow needles. Okay, nowadays we get disposable needles that are available. We need a 10 ml syringe because you're going to draw the aspirate through the needle. Usually the syringe will not have any anticoagulant, and we are going to prepare smears at the bedside of the patient before the sample clots. And then after making the smears, you're going to add the remaining aspirate into EDTA tubes, which can be taken to the lab later on and then made smears. And also in current context, I'm sure all of you will agree that we don't limit our role to just doing a morphological examination by obtaining an aspirate and biopsy. There are several other ancillary procedures that we need to do. For example, an EDTA sample is going to help us to do a flow cytometry, molecular testing, and so on. So it's very essential to appropriately collect the samples. So it's important to know what gauge needle to be used. So 11 gauge core biopsy needle is necessary. Now you may ask me, what are the complications of bone marrow aspiration? Yes, there could be local bleeding, infection at the site, but these are very, very rare. Let me tell you, even for patients with severe thrombocytopenia, several of them platelet count less than 5,000. We've done bone marrows any number of times, and I'm yet to come across a patient who has had a significant bleeding following the procedure in spite of the low platelet count. Okay, so relatively a safe procedure. And I would like to say that aspirate, it's always good to get a good concentrated aspirate. Sometimes we'll realize that the aspirate becomes very hemorrhagic and bloody. So even a small volume, only then you will get a very richly cellular aspirate. And if you look at the aspirate very carefully, you will find presence of tiny particles. You can actually see fat globules and sometimes, rarely, small bony spicules. That means you've got a very good aspirate. So instead of just getting blood in the aspirate. So this is important for us to obtain so that we are able to give a meaningful report. But sometimes, in spite of a good technique, you may land up getting not getting an adequate or a suitable marrow sample. And that's when we refer to it as a dry tap. Now, we encounter dry tap whenever there is an extensive fibrosis of the marrow, probably myelofibrosis, or even in cases like hairy cell leukemias. Sometimes when the marrow is really packed with cells, For example, in acute leukemias, it's tightly packed with cells, a very, very hypercellular marrow. Then it's difficult to get an aspirate. So in those situations, it's important to make touch imprint preparations. Even when you get hardly any aspirate, the imprint can play a good role in making a diagnosis immediately. So when you get the core biopsy, it's important to make touch imprints on this glass slide and stain them, and which will be ready within half an hour to 1 hour, and you can give a diagnosis, because you know that bone marrow biopsies are going to take much longer because they need to be decalcified. So that's what I was talking to you about, touch imprints. So imprints are as good as aspirates in certain situations for providing a primary diagnosis. And of course, the core biopsy specimen is going to take longer because you need to fix them. It has to undergo decalcification, processing, and then the sections would take at least 48 hours to be ready. So some labs do resort to making clot sections. That is nothing like, just like your cell blocks. Yeah. So basically, what are we looking at the aspirate smear and in the imprint? We are looking at a cytological assessment. Whereas if you look at the core biopsy, we are looking at the histological assessment. So irrespective of what preparation we are looking at, it's important to assess the marrow cellularity, the cell morphology, and besides that, you can look at other things like assessing the bone marrow iron. I will discuss details of it very soon. So when you get a bone marrow aspirate, it's important to plan. So it's very important for us as hematopathologists to know what the case is likely to be, have a good review of the peripheral smear, understand the need for further investigations, and plan accordingly. Because bone marrow is an invasive, painful procedure. You cannot keep repeating the procedure. So you will have to collect the required EDTA sample, heparin sample for culture, as the case may be. So when you take out the marrow, yes, we routinely, conventionally prepare smears, Leishman or MGG stain smears or cytochemical stains. We take a heparinized sample for flow cytometry. Of course, you can take an EDTA sample for flow, but then the sample has to be processed and analyzed within 24 hours. Whereas if you take a sample in heparin, you can process the sample within 48 hours. That's the advantage. Besides, a heparinized sample is also used for cytogenetics in fish, whereas an EDTA sample can be used for molecular techniques. So it's very important for us to know these basic things so that you plan and take appropriate samples which can go to the respective laboratories for various testing procedures. Yeah. So I did mention that for cytogenetics and fish, you need a heparinized sample. So what about Trephine biopsy? Again, Trephine biopsy is not going to just give us morphology. We are going to perform immunohistochemistry, in situ hybridization, and other molecular techniques can be prepared, and therefore it plays a very good role as a complementary role to the bone marrow aspirates. So let's now briefly look at what are the advantages of doing an aspirate versus a biopsy. All of us know an aspirate is obtained. You're going to quickly do a Leishman or MGG and the stain is ready in the next half an hour. So quick results are very important. And you're going to study each cell in great detail. So it's going to give you a very good cytological assessment, just like FNAC. Okay. And enumeration of marrow cellular elements. You're going to be even able to count each cell. You can perform cytochemistry. You can perform flow cytometry, you can do cytogenetics and molecular techniques, all of which on the aspirate sample. So what about the Trephine biopsy? Now, when you do a Trephine biopsy, it gives us an excellent assessment of the cellularity. Sometimes assessment of cellularity can be tricky and misleading on an aspirate, whereas the Trephine biopsy preserves the architecture. You're going to see it in its structural framework. So it's more reliable to assess cellularity. You're going to be able to pick up focal lesions like granulomas, lymphoid nodules, and etc. A very good assessment of fibrosis, which is impossible on an aspirate. You can use IHC. Sometimes you get a dry tap, you only get a Trephine biopsy. You can definitely perform IHC to make a diagnosis of leukemia, lymphoma, and so on. It's a very useful tool when we are, especially in the context of aplastic anemia, where you hardly get a marrow. Therefore, we are looking at Trephine biopsy to assess the cellularity and make a diagnosis. Definitely, it has a good role to play in metastasis. Very often, we pick up metastatic deposits when they are most unsuspected in biopsies. It also has a role in picking up certain infections, say CMV inclusions, LD bodies, and so on, cryptococcus, histoplasma. So definitely Trephine biopsy has a complementary role to Aspirate. Therefore, it's a good idea to do both Aspirate and Trephine biopsy in the same sitting. So when we look at an Aspirate, what are we going to do? As I said, you can actually count the cells. So you're going to count 500 cells or 300 cells. You're going to look at individual cell morphology. So you're going to also look at the development, the maturation, the type of erythroid maturation. Is it normoblastic, megaloblastic? Is there dysplasia? You're going to assess the myeloid erythroid ratio. Definitely assessment of iron stores by using Pearl stain is going to play a complementary role. You can do cytochemistry depending on the morphological details, whether you're suspecting a leukemia or lymphoma. And as I said, you can definitely do immunophenotyping by doing a flow and cytogenetic and molecular analysis. Now, when I look at the biopsy, as I mentioned, it is more useful to assess cellularity, but I'm not going to be able to study individual cell morphology in a way that we study it on the Aspirate. But you're going to look at the cellular relationship. You're going to be able to pick up focal lesions, assess marrow fibrosis, structural abnormalities of bone, sometimes osteopetrosis, osteopenias, all of them you could be able to pick up, which could contribute to certain hematological findings. So as I mentioned, when do I say that the bone marrow that I've got is adequate? So I should be able to see enough particles. It's not enough to get, it's not that the volume is important. It is to see that you get enough fragments. Make sure they are not crushed. Make sure when we make the smears, they're not too thick. The sample will get quickly clotted. So the smears, as I mentioned earlier, should be made at the bedside of the patient, and the rest of the sample should go into an EDTA so that the sample doesn't get clotted. Simultaneously, when you take out a core biopsy, it's important to make touch imprints. So how do you make smears? Now, all of us are familiar with this method, just like making blood smears. So this is called the push preparation, where you put a drop of bone marrow sample on a glass slide and use a spreader to spread the slide. Okay. The other way is where you are just putting a drop and making a crush preparation by overlapping it with another slide and gently spreading the drop of blood. Now, what is the advantage of the push preparation? It gives a good assessment of morphology, and you can count the cells. The cells get distributed in the trails very uniformly. But there could be a disadvantage that the cell release, sometimes if all of them get crowded around the particles, it can get difficult to count. So it depends on how the spread is. Whereas if you look at a crush preparation, morphological details are not so well preserved, so that's a disadvantage. But then the cells get somewhat spread around this smudged spread crush, and the chances of, you may not miss out on sometimes when, especially when you're searching for megakaryocytes, when they're very few in number, it's easier to pick them up because it's not a long trail that you're searching for. But in general, it's the push preparation or the smear is always better than the crush preparations. So ideally, this is what we want. That we want the cells to be spread uniformly so that we are able to assess the morphological details. So this is how you prepare. The core biopsy is touched on the glass slide very gently, because if you apply too much force, the core is going to break. So it should be a gentle touch such that the cells are preserved when you stain and you are able to study the morphology. So it's important to look at these smears macroscopically to see whether there are particles. So that's very important before. And then you also do an iron stain. So you will decide, okay, I'm going to stain 4 for Leishman, 1 for iron, and then 2 imprints. So this is something that we need to plan and always preserve the extra smears carefully for future study or analysis. As I mentioned, EDTA is important to collect an EDTA sample, but remember it can distort the cell morphology to a certain extent. So always fresh smears without anticoagulant will be most valuable in giving us good morphology. And of course, we will use the EDTA for flow and other investigations. Heparinized sample is not suitable for morphology because it can give you a blue background and a staining artifact. And it's also not suitable for molecular testing because it can interfere with PCR reactions. So it's very important for us to know what type of anticoagulant is suitable for what test. Very often, this is always a confusion among residents, both from the pathology side and from the clinical side. There's always a to and fro conversation going on in hospitals, what sample to be collected for what test. And sometimes it's also realized that certain types of samples are not collected. And remember, it's such a painful procedure. There's no way that I can collect a heparin sample subsequently. So that understanding, that knowledge and planning is very, very important. So if you're doing an MGG, it's important to fix it. Of course, if you're doing a Leishman stain, you can directly stain the smear. So as I mentioned, you have to have good number of aspirate smears, iron stain, and then the additional tests. I would like to mention at this point that it's important to always correlate the findings with the peripheral blood. So a blood smear which is done within 2 days of the marrow is important, not an old one saying 1 week ago. So what is our practice is at the time of doing bone marrow, we take a finger prick smear and correlate. Otherwise, we can make blunders. I will give you an example later on. So moving on to, so we have discussed quite a bit about the technique, the procedure, and what are the types of samples that we need to take. Now let's focus on examining the preparation, assuming that you've got a slide, a smear, which is stained with a Romanowski stain, and you are going to interpret it. So as I mentioned, the volume is not important. It's about how concentrated the cells are. Very often when you get a large volume, it's most of the time diluted with peripheral blood. So you may miss some findings. So this is the aspirate that you're going to look at. Look for particles, as I mentioned. Look at it macroscopically before you even put it under the microscope. And it should be uniformly spread and not too thick so that you are able to visualize the cells properly. Sometimes, as I mentioned, you may have bone marrow without getting any particles or fragments, especially when the marrow is packed like in acute leukemias. Even then, it is going to still play a significant role. But remember that the fragments are important to assess the cellularity, to assess the number of megakaryocytes. Otherwise, if there are no fragments and if it's diluted with peripheral blood, our overall assessment of cellularity may be unreliable and the marrow will be having more of lymphocytes and neutrophils. And because you don't see megakaryocytes, you may falsely report as megakaryocytes decreased or absent, which is not the right thing to do. So you must make sure that the marrow is adequate before you comment anything as decreased. You have to think 10 times before you say megakaryocytes are decreased in a smear which doesn't have fragments. Only if the smear has adequate number of fragments, you can comment on the cellularity as well as the number of megakaryocytes. So when do you say how many fragments are adequate is a question. I think it's there in one of my further slides, but I would like to say at least 5 to 7 fragments should be there for us to say this preparation is adequate for examination. Now, I would also like to mention that there could be certain artifacts related to taking out the sample. So sometimes you will notice when you see the aspirate or even the biopsy, the marrow space has got washed off. Then you cannot report these as hypocellular. So that's a wrong interpretation. Sometimes in a biopsy especially, usually they say that it's preferable to take a biopsy core, then do an aspirate. But sometimes many people do aspirate followed by biopsy, in which case you can get a hemorrhagic area. That's an artifact of aspiration. You can very often we encounter crush artifacts. So there are a lot of artifacts that you should be aware of, otherwise you can misinterpret. So when you have an aspirate, after looking at it macroscopically and deciding whether there are enough particles, then you're going to examine it under scanner or low power to know again, confirm that there are so many particles, and then you're going to look at the cellularity. Identify megakaryocytes. Look for clumps. So scan the smear along the particles, along the edges of the smear. Look for clumps of abnormal cells. Look for macrophages. Look for megakaryocytes, because if you don't see under low power, you're definitely going to miss these things. So a good thorough assessment of the smear under low power is absolutely essential. You should go stepwise, not miss anything. So the next thing is to go to high power under 40x, where you're going to see cell morphology clearly. So you're going to see erythroid in various stages of maturation, myeloid in various stages. So this will help us assess the myeloid erythroid ratio. It's important to perform a differential count. Very often I do see bone marrow reports without a differential count, which is not very advisable. You also look for other areas of, say, necrosis, granuloma, and so on, assess iron content. It's not easy to pick up granuloma on an aspirate, but I remember, I think, just one situation in all these years, then I was able to pick up a granuloma on a bone marrow aspirate and even demonstrate acid-fast bacillus in that. So that was very, very exciting, because it's common to pick up granulomas on the Trephine biopsy, but very uncommon to pick them up on an aspirate. So let's look at each of the cells on the bone marrow aspirate. So I just want you to recap what you learned again in physiology, the hematopoiesis, the various stages. So if you're going to look at the erythroid series, we are going to identify the proerythroblast, early normoblast, intermediate normoblast, and late normoblast. So when you look at the bone marrow, you're going to see all of them, but which of them is more common? Most of the time, you will see a predominance of intermediate and late normoblasts. Early erythroblasts and proerythroblasts are very, very few. And remember, especially in conditions, say for example, pure red cell aplasia, where you hardly see any erythroid precursors, that's when you will see 1 or 2 proerythroblasts. So otherwise, proerythroblasts are rare to pick up. You will most of the time see intermediate and late normoblasts, and very few basophilic normoblasts. So it's important to have a good understanding of the morphology to be able to recognize these stages of development. So a proerythroblast is easy to recognize because it's quite large. It is a dense blue cytoplasm, and you will see blebbing in the cytoplasm. So it's easy to identify them. Whereas early in this slide, what you're seeing is early, intermediate, as well as late normoblasts, which is differentiated based on size, based on the cytoplasmic staining. You know that the late normoblast is a pink cytoplasm, whereas early normoblast has a blue cytoplasm, and intermediate has a blue-pink cytoplasm. And as the cell matures, the size becomes smaller. So it's easy to identify. So when we look at myeloid cells, myeloid precursors, again, we are going to look for all these stages. And we all know that, yes, myeloblast, maybe 1% can still be part of the normal marrow, but otherwise, predominantly, you will see stages from myelocytes, metamyelocytes, band, form, and neutrophil. You will see very few promyelocytes. At this stage, I just want you all to remember at what stage the cell stops dividing. Up to myelocyte stage, the cells can divide. And after that, there is only maturation, no division. Okay. So you're going to look for each of these cells. So it's important for us to know the stages of granulopoiesis and be able to recognize each of them correctly to be able to pick up various disorders. So this is just each of the cells that you are, I think all of you are very familiar with this. Now, moving on to the megakaryocytic series, you have to be able to recognize a megakaryocyte and a megakaryoblast. So a megakaryoblast is a precursor, we know, of megakaryocytes, but it's got a single nucleus. If you look at it very superficially, it just looks like little larger than a lymphoblast, very again blue cytoplasm, condensed chromatin. So you may wrongly interpret it as a lymphoblast. It's actually a megakaryoblast. So it's easy to pick up megakaryocytes because they are multinucleated, they have abundant cytoplasm, and you have to look under the lopar. This is a lopar view where you're seeing fragments and all those arrows point to multiple megakaryocytes located very close to the fragment. If the smears spread well, they'll all get spread uniformly. So this is one smear where it's obviously increased in number and you're able to see it like this. As I mentioned earlier, you should see at least 5 to 7 particles on the aspirate and 5 to 7 marrow spaces on the biopsy to call it adequate. There are certain important points that you need to consider when you report a bone marrow. I mentioned myeloid erythroid ratio, which means the ratio of all granulocyte series, including the monocytic cells, and of course the erythroid series. In the marrow, you are going to definitely comment on the myeloid erythroid ratio. We are also going to mention the percentage of lymphocytes and plasma cells. It's good to do a differential count of 200 to 300 cells. But when we suspect certain types of abnormality, say for example myelodysplastic syndrome, where the blast counts are borderline, it is mandatory to do a 500 cell count. So also plasma cells. When we have a myeloma, usually remember that myeloma involvement of the bone marrow is very patchy. So there could be, in fact, if you count 3 different smears, you can get 3 different counts. So it's important to count 500 cells in these cases. And as I mentioned, it's very, very important to get a CBC sample and a peripheral smear done in the same sitting and correlate them. Otherwise, you're going to miss some diagnosis. So after having assessed under low PAR and high PAR, then you're going to examine under oil immersion to assess the cellular detail. So as I mentioned earlier, that the cellularity is based on the age. So as one grows older, the cellularity decreases. This is an important. So when you have to see a bone marrow, you have to ask for the patient's age. A good clinical information is important. So this is essentially to show you comparison between hypocellular aspirate, which is on my right, and a normocellular aspirate, which is on my left. And what is in the middle is a hypercellular bone marrow. This is just to compare cellularity of the fragment. So when we look at bone marrow aspirate and imprint, as I mentioned, you're going to look at the adequacy. You're going to assess the cellularity, classify it as normocellular, hyper or hypocellular. You're going to look at the myeloid erythroid ratio. You're going to assess the maturation of the erythroid precursors. Look at the granulocyte precursors, see whether there is any maturation arrest or any dysplastic changes. You're going to assess the megakaryocytes in terms of their number, look for immature forms, look at the nuclear morphology, look for dysplasia. You're also going to look for lymphocytes, plasma cells, mast cells, very, very important, especially when you're dealing with an aplastic anemia or any other condition associated with mast cell disease. Going to look for eosinophils, basophils, macrophages, especially in the setting of storage disorders or hemophagocytic syndromes. Looking for macrophages with evidence of hemophagocytosis can become important. So in these situations, you may have to stain many more smears, more than what you will screen normally, before you say something is negative. I always tell my students, it's very difficult to say something is not there, because you should have searched so much, you should have evaluated so many smears before saying something is not there, before saying blasts are not there. No hemophagocytosis is a very difficult diagnosis. But to say hemophagocytosis is there becomes easy because you're already seeing it. But if I want to tell a clinician it is not there, I must have thoroughly searched at least 6 or 7 smears, and before I can say that evidence is not there. So you have to do justice to the bone marrow. Yes. So there are guidelines, the ICSH recommendations as to how many cells. As I already mentioned, you have to count 500 cells when we are looking for a diagnosis, say myelodysplastic syndrome, say plasma cell myeloma. And it's important to count in more than one smear. And it's important to have more than one observer looking at the smears. So ideally, all bone marrows, if you're working in a place where, it's a team of pathologists, always should have at least 2 people looking at every bone marrow. That adds great value, not just one person, because it's easy to miss certain things. Yeah. So a 500 cell count is important because sometimes there could be sampling errors, dilution. So even in a smear, sometimes in the same case, especially I've encountered this in the setting of aplastic anemia. You have one smear which is nicely hypocellular, all the fragments are hypocellular. You pick up the next smear and you will see very cellular fragments, lot of erythroid precursors. Why is that? Maybe the needle went into a hot spot where the marrow production is normal and it's full of erythroid precursors. Whereas in the other smear, you just see fat, lymphocytes, and plasma cells, totally contradicting findings. So always screen at least 3 or 4 smears before you write your report. You will encounter these challenges when you practice routinely. So that's very, very important. As I mentioned earlier, it's also important to correlate with the smear. I must tell you, I must admit a mistake that I made many years ago. We had a case referred only a bone marrow slide for review. They said it was a 5-year-old child. I still remember, and I keep narrating this. Very cellular marrow, everything, all the maturation was normal, but megakaryocytes were increased. And they said clinically the child is bleeding. So definitely all of us would think of immune thrombocytopenia because there is no diagnostic. Bone marrow is not diagnostic, but you can always say, yes, in the setting of thrombocytopenia, clinical bleeding, yes, if megakaryocytes are increased, you would think of ITP. So that's what was the diagnosis that was informed. This was a child in some other city. And then I think they started the patient with steroids, but the child did not improve, in fact, deteriorated. So then they said, okay, we will shift the patient to your hospital, and the child came to our hospital. Obviously, we got a CBC and peripheral smear, and to my surprise, of course, thrombocytopenia was there, but we did pick up several other abnormalities which pointed to a presence of a microangiopathic hemolytic anemia. So there also you have thrombocytopenia, but the smear showed fragmentation of red cells, nucleated RBCs. Therefore, in any such case, bone marrow in this case will show only increased megakaryocytes. So just don't, it's so important to correlate. So the diagnosis is totally different. The treatment, the way you manage these patients are different. Always report the peripheral blood smear in conjunction with the bone marrow aspirate and never the bone marrow aspirate in isolation. This was a lesson learned. And then from on, we made it mandatory that every time a bone marrow is done, we should take a finger prick smear and look at them together before we release a report. So I did talk about the nucleated cells. I told you that you have to count both the granulocytes, the precursors of granulocytes, erythroid series. Remember, we don't count megakaryocytes, we don't count mast cells, osteoblasts, osteoclasts, etc. We only count the hemopoietic elements. So this is how, a good smear would look. And differential count can be challenging sometimes, especially when there are, as I said, one smear shows taken from a hot spot will show predominantly erythroid, another which will show a very hypocellular marrow. And that is why it's important to do a differential count on more than one smear before you give your final report. It's important to write the myeloid erythroid ratio, make a mention of other findings, the type of maturation, the cellularity, the presence of eosinophils, mast cells, and so on in the report. Okay. Always refer to normal ranges that are available in textbooks. Our Indian, we don't have our own Indian reference range because we understand that it's difficult to establish population reference ranges for bone marrow. But there are enough textbooks available for different ages. The normal range for children are different from adults and for elderly. So please refer to the age and report it carefully. I'm sure all of you will recognize this. So this is a Prussian blue stain. Of course, it demonstrates increase in iron granules, lot of siderotic granules. It is very clearly evident. So what is the role of assessing bone marrow iron? So bone marrow iron usually is an integral part of bone marrow assessment. Nowadays, we don't really do bone marrows for assessing, diagnosing megaloblastic anemia. In my early days, every day we used to have a bone marrow, at least 2 bone marrows with megaloblastic anemia. Typically, iron would be increased. We used to see ring sideroblasts very often. But today, you have several simpler ways of diagnosing megaloblastic anemias. You have serum B12, folate assays easily available. Nobody does a bone marrow. Of course, assessment of iron for inherited sideroblastic anemia, for refractory anemia with ring sideroblasts, which is a type of myelodysplastic syndrome, are all very important. That is why it's essential always to do a bone marrow iron. Literature says you should assess as high as at least 9 particles. So 7 to 9 particles should be reviewed. As I mentioned earlier, if you have to say iron is not there is challenging, because you should have seen that many fragments rather than just look at 1 or 2 and say there is no iron. So I have to say with confidence that iron is 0. So for which I should have assessed enough number of particles. So that becomes important. All of us are familiar with grading of iron. So iron is graded from grade 0 to grade 6. And the normal is grade 1 to 3. Anything more than grade 4 is increased iron. So again, it's not just the grading of iron. It's important to look at the distribution of iron. The iron can be in the reticuloendothelial cells and in the erythroid precursors. Now, in the setting of, say, a hypocellular marrow, like aplastic anemia, say for an infection, you will see a lot of iron in the reticuloendothelial cells. But in the setting of, say, megaloblastic anemia, sideroblastic anemias, MDS, you will see iron in the erythroid precursors. So I think I have mentioned about it, ring sideroblasts, where you see iron granules around the nucleus of an erythroid precursors. At least 5, more than 5 siderotic granules located around the nucleus of erythroid precursors, which will be called a ring sideroblast. And you should count 100 erythroid precursors and identify how many of them are ring sideroblasts to make a diagnosis of refractory anemia with ring sideroblasts. Okay. So coming to how you're going to summarize the report. Very important to assess adequacy. I want to stress this point again because I have seen several reports where if fragments are not there, there is not enough marrow and it's been wrongly labeled as a hypocellular marrow. Never do that. It's important to assess that there are enough fragments and there are adequately cellular and good cell trails. Otherwise, you're going to make a blunder. So that's very important. Make a descriptive comment on each of the cell line. Definitely do a differential count. Assess the myeloid erythroid ratio. Look at the type of maturation. Look at evidences of dyserythropoiesis. Correlate it with cytochemistry whenever applicable. And write a complete impression in the context of a clinical background and make appropriate recommendations. And always make a note of what are the peripheral blood smear finding in that given case at that point of time. Because you all know that blood smear findings are very dynamic. There can be many changes between yesterday and today. So you have to correlate it at that given point and make a suitable recommendation because clinician wants you to give a direction to that case. So you have to write appropriately in a given clinical context. As I mentioned, yes, the bone marrow aspirate one can do a flow cytometry and cytogenetics, molecular genetics. Now I'll quickly move on to bone marrow Trephine biopsy. Now, again, this is such a nice long Trephine, and we have a very senior hematologist, clinical hematologist. He really gets a nice long core of bone, 2 centimeters long. Nobody else can give us. So the moment we see such a long biopsy, we know it is sir who has done it. But it's a skill, it's an art. You have to really be able to train yourself to get such a good biopsy. And when you get such a good biopsy, you have adequate marrow spaces, 8 or 10 marrow spaces. So then the assessment of the bone marrow biopsy becomes easy. Otherwise, if the biopsy is too small or fragmented, and if you hardly have 1 or 2 spaces, you're going to be missing on many things, especially as I mentioned, In bone marrow biopsy, we are going to look for focal lesions, say metastasis, granuloma, which can be easily missed if the biopsy is not adequate. And in certain situations, it's very important to do a bilateral Trephine biopsy so that we don't miss out on focal lesions, especially in myelomas, lymphomas, staging of neuroblastoma. In all these cases, a bilateral Trephine biopsy is preferred. So good fixation is important so that you get a good morphology, you're able to visualize cells well, and also you are able to perform IHCs. So various fixatives are available. One could use, the most commonly used fixative is neutral buffered formalin. Decalcification, again, there are several agents which can be used as decalcifying agents, EDTA, formic acid. It depends, each institution standardizes these protocols to suit their requirement. And we could do several stains. Most essential is H&E and a reticulin stain go hand in hand. Of course, depending on the case, one may have to resort to doing others in, say, Masson's trichrome when you're suspecting marrow fibrosis, collagen fibrosis. When you want to look for amyloid, Congo red, ZN stain very often used, especially in the setting of fever of unknown origin, you're suspecting the granuloma, in a case of HIV infection and so on. So you have a whole lot of stains that you could play with to make a meaningful diagnosis. This is a recap of what we saw in the earlier slides. I would like to stress here that the topography is important, because here we are looking at architecture. In contrast to what you saw in an aspirate, you're looking at individual cellular morphological details. In the biopsy, you're looking at the architectural framework. So if you look, for example, this very clearly tells us the location of each type of cell. Now, when you look at the bone and immediate subcortical space, and if the needle goes into that area, you will get a very low cellularity. So you will make a wrong assessment that the marrow is hypocellular. So always you have to go deeper into the section where you look at the cellular areas. And you will realize that the immature granulocytes are always in the paratrabecular regions, and the erythroid precursors form islands, and they are more towards the center of the bone marrow space. So you will see them in groups and clusters in the intertrabecular spaces. And of course, megakaryocytes, you will see them usually around the sinusoids and the blood vessels. So what you're seeing here is a lymphoid aggregate. This is very common, especially if you're looking at bone marrow biopsies in elderly. It's quite common to see a very benign looking lymphoid aggregate. You should not jump into the conclusion that it's a lymphoma. Study the marrow carefully. Correlate it with the aspirate, peripheral blood, and other clinical findings before we jump into a conclusion. So as I mentioned, this is just to show you how it looks on the biopsy versus on the aspirate. So if you look at erythroid, they're very densely stained nucleus, whereas the myeloid cells are more paler, more dispersed chromatin. So it's a strikingly different morphology, which you will be able to appreciate. Of course, megakaryocytes are always easy to recognize because they stand out because of the size and the multinucleate morphology. Immature megakaryocytes can be missed. So be careful about micromegakaryocytes. One could easily miss if we don't think about it. Now, the same assessment of cellularity. So this is a picture, just to this photograph depicts a hypocellular, a normal, and a hypercellular Trephine biopsy. So cellularity assessment, just like how we assessed on an aspirate, you have to assess on the biopsy. I did mention one challenge where in the subcortical region, if you're looking only in those areas, you will falsely make an interpretation that the marrow is hypocellular. So it's important to look at deeper sections to assess the cellularity. So this is to clearly show you the difference. And of course, you have to keep in mind the age of the patient. So this is where I just want to demonstrate that very, very hypocellular in the subcortical region. But if you go deeper down, you see a nicely cellular marrow. Yeah. So again, adequacy. You have to see at least 6 or 7 spaces, marrow spaces with cells. Sometimes the marrow spaces will get washed off, then you cannot comment on it. So adequacy will help us assess cellularity and the percentage of each of the cells, the myeloid versus erythroid. Of course, here fibrosis is important. Okay, the presence of granuloma, lymphoid infiltrate I already mentioned. So this slide very nicely shows us the striking difference between erythroid and myeloid. The darkly stained, very rounded cells are the erythroid precursors. You also see an artifactual halo around each of them, whereas the myeloid cells are more pale, very dispersed chromatin and somewhat bigger. So it's very easy, but you have to have a good thin section to be able to appreciate. If your section is very thick, folded with lot of crush artifact, you cannot make out any of these things. Now here is a case where, see, you're seeing a H&E section on the right side, where this area at the lower part of the biopsy looks like, you know, very spindle shaped and looks like it's fibrosis. But again, I said, you have to assess in the clinical context and you should have a high index of suspicion. Remember, on the left side, it's a toluidine blue and it's highlighting all the mast cells. So if we did not do a toluidine blue, we are going to miss out on the mast cells, and I'm going to wrongly report that there is marked increase in marrow fibrosis, which is incorrect. So one has to be very, very careful in interpreting these. So same logic, assess the Trephine biopsy under low par. As I mentioned, adequacy, the cell distribution pattern, the cellularity, look for focal lesions, look for megakaryocytes, assess their number, identify, locate abnormal cell clusters, look at the thickness of the trabeculae, very important. Look for increased osteoblastic or osteoclastic activity. Then it is examined under higher par, 40x usually, to look at individual cells that I just showed you, erythroid, myeloid, and the megakaryocyte. And very rarely we use oil immersion, only if you have to look for some intracytoplasmic inclusions or rods, or sometimes, say, for example, you're looking for LD body and other things, histoplasma, then we may look at oil. Otherwise, usually we do not look under oil immersion. Now, the last part of my discussion, a little bit about how to assess bone marrow fibrosis. More often they are secondary rather than primary. Quite often, especially when there is metastasis, breast cancer, prostate cancer, you get a lot of fibrosis. You say desmoplastic reaction. So also with lymphomas. And of course, in primary myelofibrosis, various myeloproliferative neoplasms, you do get fibrosis. So there are many, many causes that I have listed here. Myeloproliferative neoplasms, sometimes with certain types of MDS, you can get fibrosis, acute leukemias, lymphomas, typically in hairy cell leukemias, multiple myeloma, and I mentioned metastasis. Remember, there are many non-neoplastic causes of fibrosis, infections, certain types of graft versus host disease, patients with autoimmune disorders, osteopetrosis, rarely Paget's disease. In all these conditions also you can get fibrosis. So reticulin fibrosis is quite common. And as I said, it's increased in both neoplastic and non-neoplastic conditions. And as this evolves, it becomes collagenous. So sometimes you have to do not just a reticulin stain, you have to do a Masson trichrome stain to demonstrate collagen, increased collagen. Remember, reticulin fibrosis is to a certain extent reversible. But once collagenous fibrosis sets in, it's unlikely that it is reversible. So evaluation of bone marrow fibrosis in the clinical context is very important. Look for organomegaly, look for whether patient has a huge spleen. Then the pointers are more towards myelofibrosis, where you have a leukoerythroblastic blood picture, thrombocytopenia, NRBCs in the circulation, then more likely that you're dealing with a myelofibrosis. That's why correlation with peripheral smear becomes very, very important. Of course, molecular studies will play an important role in the diagnosis of myeloproliferative neoplasms. So very often, I mean, even in a normal marrow, you find fine reticulin framework, which is quite normal, delicate. Whereas, look at this. This is in a case of hairy cell leukemia, where the reticulin framework is still thin, but it's running through individual cells across the entire marrow. This is very typical of hairy cell leukemia. It's important to grade the fibrosis. There are different types of grading. The commonly used is a European consensus scoring system, which is also adapted by the WHO classification. So they grade it as 0 to grade 3. So this is the grading, where grade 0 is considered normal. Even in a normal bone marrow, you will find some reticulin, which is grade 0, whereas grade 3 is diffuse, dense increase in reticulin framework with extensive intersection and coarse bundles of collagen associated with significant osteosclerosis. That is grade 3, and then you have grade 0. So this is what is usually used. So it's important to mention the grade and what grading or the scoring system that we are referring to. There are several pitfalls in grading bone marrow reticulin fibrosis. For example, if you have a very tiny biopsy with lot of crush artifact, then you're going to misinterpret the reticulin fibrosis. If the section is too thick, you're going to overestimate the fibers. Quality of staining is very, very important. Overstaining will make assessment of fibrosis very, very challenging. So also understaining, then you may not be able to visualize the reticulin fibers. So you must look for internal control. Around the sinusoids, is there the reticulin, is it visible? That is an internal control. You must always look for it to know whether your stain has worked well. Otherwise, you may have to repeat it. So also, when you look at Masson's trichrome, again, the size of the biopsy, it's important that section doesn't have any artifact. Good standardized staining is very, very important. Sometimes, rarely you will see osteosclerosis, where the marrow spaces are narrowed, the trabeculae are widened. So it depends on how the sections are cut. Otherwise, you may misinterpret it as osteosclerosis. A word about bone marrow necrosis. Sometimes you will see just pink marrow spaces with very hazy tissue cellular architecture where you can't really appreciate individual cells. Be very careful whether it's a processing problem or actual bone marrow necrosis. Sometimes if the tissue is not well processed, you may be faced with a challenge, and then it can become very, very challenging. But bone marrow necrosis is common in certain types of infections, even with tuberculosis, with acute leukemias, with metastasis, in SLE and so on. Patients who are receiving chemo and radiotherapy, it's quite common to see bone marrow necrosis. So it's important to assess and document the findings appropriately. And whenever we see bone marrow, very often we are carried away by the cells. We forget to look at the extracellular matrix. So very important to focus on the matrix because it can contribute to diagnosis in many, many situations. One such example is a myeloid. So the last part of the session, immunohistochemistry has a very important role, very critical for diagnosis, especially lymphomas, leukemias, and also for follow-up prognosis and therapy. Detection of disease, assignment of lineage, maturation stage, clonality, especially in the context of plasma cell, you do kappa lambda stain to assess clonality. So it becomes very critical. And again, there are guidelines, ICSH guidelines for standardization of immunohistochemistry, use of appropriate controls, and appropriate interpretation. Again, there are several pitfalls in assessing IHC staining on a bone marrow biopsy, more challenging than any other tissue. It could be a topic by itself for discussion. So I'm not going to touch upon these. So I don't know, Dr. Aditya, do we have some time for one or two cases? I'm just going to go. Yes?
Please go.
Okay, yeah. So this is, I don't know, I'm sure all of you, it's glaring when now it becomes very easy. You are seeing a very large cell with abundant cytoplasm with a very innocuous nucleus. Very striking, all of us will jump into the conclusion that it's a macrophage. This is a typical of a storage disorder, Gaucher's disease. But what I want to tell you is that this is not a bone marrow aspirate. This is actually an imprint smear. Very, very challenging to pick up these cells on imprint. And remember, there was only one case that I came across in all these years, almost 3 decades. This was a patient who was much older. This was a 17-year-old lady who did not have typical features of storage, very vague symptoms, pancytopenia. Therefore, since there was no diagnosis, the clinician decided to do a bone marrow. Aspirate was a dry tap. We were very lucky to pick up a storage cell on an imprint. So it has a big role to play. So, but if I did not scan the imprint carefully, it's very, very easy to miss. It's not that they are flooded. There will be one occasional cell that you will pick up. So that's very, very important. Of course, This setting is very, very rare, but it can happen in our practice and one has to remember. Therefore, a very diligent screening of even an imprint smear, even a scanty preparation. Sometimes you may want to stain all the material that you have, not even leave out a drop. You may have 10 bone marrow smears, stain it and screen all of them before you say something is negative. I kept repeating that it's more difficult to say something is not there rather than say something is there. So it's important to screen, make a thorough job before you report that something is missing. Okay. So this is a very important role of imprint. Imprints play a very important role. That's why I showed this, especially when you have a dry tap, you don't have an aspirate. Imprints can even pick up a storage disorder, leave alone even leukemias, myelomas. You can pick up and you can give the diagnosis on the same day. Biopsy is going to come 3 days later. So that is the value of imprint. So I would suggest that every time you do a bone marrow aspirate, always take a biopsy and an imprint, and the imprint and the aspirate gets stained then and there and reported on the same day. Whereas, of course, the biopsy is going to take a bit longer because of the processing, and they all have their own role to play in clinical diagnosis. Now, this is another very, very interesting case. What I'm showing you is actually not a peripheral smear. This is a bone marrow and the arrow pointing towards sickle cell. Yes, we all know sickle cell is picked up on the peripheral smear, but this was a case where peripheral smear didn't get picked up. And of course, you have electrophoresis, HPLC, and so on. But there was no clinical suspicion at all in this case. Unexplained anemia, a bone marrow was done, and that one sickle cell was picked up on the bone marrow aspirate. Very, very challenging. And the next slide I will show you is even more interesting. Even in the Trephine biopsy, a sickle cell could be picked up. That's very, very rare. I haven't seen. This was for my professor's case, and she had picked it up and shown. And after that, I have not seen. So all the time trying to say is, it's important not just to look at it superficially, look at the erythroid myeloid, look at the background, look for the background RBCs. They may show you something that is so important. There are cases where even in the bone marrow, we picked up LE cell. So very important to study it very carefully and look at it really well. Assess everything before you give out a report. So just that is the purpose of showing these two, not to discuss a big case. Okay, the same sickle in a higher magnification is what I'm showing here. This is a Trephine biopsy. Again, what the arrow points is to a sort of an ill-defined granuloma. There is no giant cell, but there is a group of epithelioid cells and lymphocytes typical of HIV infection. Sometimes you will see these granulomas in the corner and you may miss it. That's why taking deeper sections become important, especially when you have no diagnosis and just non-specific findings. You have to evaluate further. You have to take deeper sections. You have to assess the marrow very carefully. You may pick up a tiny granuloma, which goes a long way in making a diagnosis. Now, this I think is the last case where I have shown. It's just to demonstrate amyloid in the, this is in the biopsy. And of course, it is stained by Congo red. So extracellular matrix. And in a case like this, again, correlation is important. Look for other findings. You will always find lymphocytes, plasma cells in association with the background amyloid. So when you report a Trephine biopsy, always reported in correlation with the aspirate findings. Sometimes there could be discrepancies and you have to account for the discrepancies. You should justify. I always tell my students, when you see some observations, first ask questions to yourself. Justify to yourself, then you can justify to anybody. So certain questions should crop up in your own minds and you should find answers to them so that when you're discussing the case with the clinician, you have ready answers for anything that he or she may ask. And another important thing, the finding that you're seeing now should be correlated with the previous results in the same patient whenever relevant. There could be patients who go through repeat biopsies for various reasons. Always correlate with the previous biopsy and correlate with other ancillary investigations, and it should be a comprehensive report. I just want to draw your attention to certain pitfalls. Sometimes bone marrow aspirate can be done when it's really not indicated, or vice versa, bone marrow is not done when it's really indicated. Then again, you can make blunders. Bone marrow, especially when you have focal lesions, when there are radiological lytic lesions, it's important to do it in that location rather than do it in a wrong location. So look for radiological abnormalities, discuss with the clinician before doing the bone marrow, assess it properly in the clinical context and with the other tests that are available to you. Sometimes you can give a false negative report because, as I said, if it's a hemodiluted sample and marrow is not representative, you may miss a diagnosis. You may not get enough plasma cells. You may not pick up a malignancy. You may not pick up hemophagocytosis, essentially due to sampling error. So in those cases, it's important to say bone marrow is hemodiluted, inadequate sample, aparticulate, and therefore, if there is a strong clinical need, you may have to repeat the marrow. Okay, so quite often bone marrow aspirates can go misinterpreted. Okay, and similarly, Trephine biopsy, if the biopsy is too small, if there is lot of distortion, crush artifact, inadequately, improperly processed, too thick a section, and so this can cause misleading results. So a request for bone marrow examination should be regarded as a request for consultation from a hematopathologist and not just to perform a technical procedure. So the hematologist should not be obtaining and just making an interpretation of aspirate in isolation, correlate with clinical details, correlate with biopsy findings, and interpret it in a given context. So a combined report to merge all the information will give you a comprehensive, meaningful diagnosis in a given clinical setting. And of course, a final integrated consensus conclusion with as and when required, be it flow cytometry, cytogenetics, molecular, and that is the ideal situation. May not be feasible in all settings, but that goes a long way in providing a meaningful diagnosis for a patient, for the clinician who is managing a case. So I would like to summarize that bone marrow is an essential investigation, very often performed. So it's important for us as hematopathologists to look at it in the context of clinical case, assess the aspirate and biopsy together. And of course, today we have a lot of supplementary tests, immunophenotyping, cytogenetics, and molecular genetics, which will go a long way in giving a meaningful diagnosis. So with this, I would like to conclude this presentation. And thank you very much for giving me this opportunity. And I hope I have not exceeded time too much. Shall I stop?
Thank you, ma'am. Thank you, ma'am, for the most elaborated, informative, and lucid talk. I personally was so involved in listening to the talk that it was more of image-based presentation. They say that image-based presentation makes the student keep it in memory for a longer time. Thank you, ma'am. And let's take up the questions. We have one question from Dr. Nitin Paul from Amala Medical College. He asks, what is the criteria to diagnose megakaryocytic hyperplasia in bone marrow aspiration and Trephine biopsy?
A very good question. So as I was mentioning, so first of all, megakaryocytic hyperplasia is only a finding, not a diagnosis. Okay, so you're just assessing the number of megakaryocytes. So I would think that you have to again assess it in a given clinical context. I would want to know the age of the patient. I want to know whether the marrow is adequate, first of all, both in the aspirate and biopsy. I should be able to see enough fragments. And as I mentioned earlier, to assess number, you always prefer to look at the Trephine biopsy. Although, like I showed you in one of my photographs, where, it was very obvious that megakaryocytes were increased. So if you find if the marrow is adequate with enough particles and in one trail you see, normally you tend to see 2 to 3 megakaryocytes in a trail. But if you have many, if you have 5, 7 and more, then definitely it's easy to say megakaryocytes are increased. But it can be challenging. The distribution can be uneven within the same smear, between the trails, and between multiple smears of the same case. So it's important to look at the biopsy as well. There could be situations where you say decreased megakaryocytes on the aspirate, because of inadequate material. And then when you see the biopsy, you're shocked. You see megakaryocytes are increased because you're going to cell architecture is well preserved. You're going to look at marrow spaces and you're going to look at assess megakaryocytes. So usually you can assess them in low power itself because they're very easy to see, very easy to visualize. And within one marrow space, if you see more than 3, and in every marrow space you see at least 3 or 4, then it's easy to say that they are increased. But it's not a diagnosis, it's only a finding. So you have to correlate this finding in a given context to make a meaningful diagnosis. I hope I have answered your question, Nitin.
Okay, ma'am. Thank you. I hope that answers it. I have a personal question, which once myself and my friend Dr. Shiv from Armed Force Medical College, we had a discussion. When do we call a megakaryocyte hyperlobated?
Good question. Yes. This again depends on how the section is made. You will have realized that if it's a cross section, sometimes the same lobe, you will get disjointed lobes and it can falsely look as hyperlobated megakaryocyte. So normally it's very difficult on a biopsy to assess the number of lobes. It's easier to assess the number of lobes on the aspirate. But then having said that, it's important to look at it together, the aspirate and the biopsy together. So usually when you see hyperlobated megakaryocytes, you will also see that the sizes are larger. Okay, and as I said, it's very challenging to sit and count the lobes because they could be overlapping. But it's not that just one megakaryocyte you're going to label it as hyperlobated. So if you see a significant number of megakaryocytes showing more than say 10 to 12 lobes in each of them, then obviously, because normally you will see maybe 6 or 8 lobes, that is common. But if you see in every other megakaryocyte, which is a bigger, and you're seeing 12 lobes, 14 lobes, and then it becomes easy. And again, the setting is important. I'm not just looking at counting megakaryocytes lobes and saying increased lobation. I'm looking at the setting. I have several other parameters that I can fall back on. I know the clinical background. I know the platelet count. I have made assessment of megakaryocytes, and I know whether I'm suspecting MDS or myeloproliferative neoplasm. So everything, it's always multiple findings put together, and you don't just go by only number of lobes or only number of megakaryocytes. You're putting in several things. It's like mathematics, I keep telling my students. It's about putting 2 and 2 together and make a meaningful diagnosis. So I won't really worry so much about number of lobes alone, but I would put it in the right perspective to make a meaningful interpretation.
Okay, ma'am. There's another question from Alisha Kumari. She asks how to calculate myeloid erythroid ratio.
Yes, so that's very relevant. You have to do a differential count. I did describe it quite a bit in detail, I thought. You're supposed to count all the nucleated cells. So what are the nucleated cells that you will not count? I did mention you don't count megakaryocytes, you don't count osteoblast, osteoclast, mast cells, but you definitely will count erythroid cells, all the myeloid precursors. You will count lymphocytes, plasma cells, eosinophils, basophils, monocytes, and all these cells you're going to count. So when you count, it's important to identify where to count. So that's why it's important to scan the smear thoroughly under low power and choose an area where it's not too blood mixed, where you don't see many smudged cells, where you can't make out cell morphology. So pick up a relevant trail where cell morphology is preserved and you have a long enough to trail at least to count 200 cells in continuity. You can't count it haphazardly, then your assessment will become inaccurate. So then you're going to you all would have been familiar with the counters. You're going to keep counting erythroid, neutrophil, band form, myelocyte, metamyelocyte, promyelocyte, as the case may be, as you encounter cell in oil immersion, or even in hyper, it's good enough to count. You count at least 200 cells. So having counted 200 cells, you will know how many you got erythroid. So maybe you got 40% erythroid. The remaining are myeloid and lymphocytes. So that is how you assess the erythroid myeloid. So if I've got 40 erythroid and maybe 10 are lymphocytes and remaining 50 are myeloid, so it's easy to assess the myeloid erythroid ratio. So that's how we go about doing a differential count on minimum of 200 cells, if not 300. Ideal, I said, is 500, especially if you're looking at it in the context of, an MDS or a leukemia where blast count assessment becomes important for diagnosis. Then you definitely have to count 500 cells and then make an assessment of myeloid erythroid ratio. I hope I have been clear.
Yes, ma'am. There's a last question from Dr. Archana Bhatt, ma'am. Ma'am is asking, can you tell us about post-transfusion changes, if at all, in bone marrow morphology?
Okay. I would anticipate changes in the peripheral blood more than in the bone marrow. But in the context of, say, for example, if we have given patient vitamin B12, okay, so the maturation, erythroid maturation is going to quickly revert. Let's assume that I have a patient who has a severe megaloblastic anemia and he has received, even if you give a transfusion, it's going to have, the blood is going to have B12 and even micronutrient. It's only a micronutrient, and that much small quantity of B12 available in the blood is going to quickly revert his megaloblastic erythropoiesis to normoblastic erythropoiesis. So that's one change that I could anticipate in this setting. But otherwise, transfusion is not going to much alter bone marrow morphology, except in this setting. Otherwise, it would alter more of peripheral blood morphology. And again, the duration between transfusion and the changes is something that we have to keep in mind. Especially, so you may see, if you're looking at the peripheral blood, you may see a lot of, a two-cell population, especially if the patient has a microcytic hypochromic anemia and you've transfused blood, you're going to see normocytes and microcytes. You're going to see a dimorphic population. And that can be seen even in the background RBCs of the bone marrow. So that's something important to note. Thanks, ma'am, for asking that question. Thank you.
Okay, thank you, ma'am, for taking us through the journey. It was nice listening to the talk and having answered all our questions. Thank you for your talk, ma'am, and I thank all the audience for joining. I thank KCIAPM, Dr. Aditya sir, for providing me this opportunity. I think we will be closing the session now. Thank you, ma'am.
So thank you very much, members of the KCIAPM, and I look forward to more such opportunities to participate. Thank you very much.
Thanks a lot, ma'am.
Thank you, ma'am.